you for having me here. I'm Zach Warren. I am a clinical psychologist and executive director of our Autism Institute at Vanderbilt University called Triad. And at the outset, I want to say that I'm fortunate to be presenting on behalf of an amazing team at my own university, some of whom you will hear from today. And while I get a lot of credit for some of the work of these talks, that everything I'll be presenting today is really coming from an amazing team of researchers, clinicians, and trainers who help realize this work. And at the beginning, I'm just going to give a bit of perspective of our challenges and what we're struggling with in terms of providing enhanced care to children with autism across the lifespan. So I'll talk a little bit about our journey in terms of creating better systems for early identification, including what we've been doing in terms of the realms of telemedicine. And for some of you, I'll be providing a training later on in our new tool, the tele-ASDPs. It's not so new anymore. It was a little bit before the pandemic, so it's probably 7 to 9 years old at this point. Talk a lot about how we're trying to build capacity to serve autistic individuals across the lifespan, and results in data from some of our trials, the things that have gone well and some of the things that have been harder to put into motion. All of the talks today, including those of colleagues, are presented with a lens towards thinking about the benefits and limits of our current systems for screening, assessment, and treatment, so that we may improve the lives and think about future lines of development over time. I do receive funding from a number of different sources. The work I will talk about today has been supported by NIMH, the Department of Defense, and the Department of Disability and Aging. So the overall context, yeah, lower, slower, both. Okay, all right, you're gonna have to do that again then, or lots of it over time. So to set the context for this work, for the past 2 decades, really for the past 4 decades, folks have been struggling to provide adequate care to children with autism and their families. And we've been under tremendous pressure to do it better, to be able to implement better models for screening, build capacity for high quality evaluation, and to think about lifespan treatment and support for autistic individuals. For much of that time, we've only been dipping our toes into thinking about novel paradigms for things like telemedicine, or new tools, or differing approaches to treatment. And we know that there's a lot we need to do to improve. Our context is exactly 20 years ago in the US, they put out practice parameters saying all children should be screened early. So this is a slide from the American Academy of Pediatrics saying that when a child goes in for a well visit at 18 months or 24 months, we should screen for autism, which is wonderful in concept. And what we have seen in the past decade is that we're very good at handing a form to families to fill out or to ask some of these questions, but we're not so good at terms of figuring out what needs to happen next. A form like this, where you're screening a general population, can actually flag 7 to 9% of the total population. And if you think about, if you increase screening, you're increasing referrals to oftentimes diagnostic centers that are already struggling with tremendous waits, right? And what can happen is those waits can become longer. In that same period where we said all children should be screened and potentially referred for services, we've seen a tremendous increase in the known prevalence of autism, moving from 1 in 150 when I started my job. I think sometimes I was tricked into my job because it was 1 in 150 at that time. And now in my state at home, it's actually 1 in 29. That's such a tremendous number, right? And our workforce has not increased at the same rate at all. In fact, in some of our developmental and behavioral subspecialties, our medical partners, for example, the number of trained providers is actually decreasing in some specialties like developmental and behavioral pediatrics. So ideally, screening leads to action and service. Unfortunately, our reality is that it can lead to waits. It can lead to sort of traffic jams and challenges moving forward, which places families and children in very challenging positions. It places providers in very challenging positions, and it places those who are trying to build better systems in uniquely challenging positions as well. Historically, the standard components of diagnostic assessment, while the test name may vary somewhat, they all tend to be extremely intensive in terms of time spent. Right? A traditional evaluation 20 years ago might be somewhere between 4 to 12 hours of service, right? And that's a lot for a single child. And if you think about sort of multiplying that by 1 in 31 in terms of our prevalence rate, coming up with the time and resources to be able to do this on a population level is actually impossible. It really is, right? No one has been able to achieve it, right? And so we've had to think about different ways to be able to think about assessments over time, right? So we've been thinking a lot about new tools, new processes, new providers who might be able to introduce sort of different types of assessment to reduce weights and to motivate sort of adequate support and service over time. The idea that all children who are screened for autism should be seen under one model, particular resource-intensive model, doesn't work very well, right? And we've been thinking about shifting to novel pathways rather than a one-size-fits-all approach towards pathways where we might be able to do things differently for certain profiles of children in certain circumstances. I would argue intensively that long and resource intensive evaluations are not always ideal, right? Is it ideal that a child might have to wait a year or two, right? Is it ideal that a family might have to travel many kilometers to be able to try and access a center, or may not be able to access it at all? Is it ideal when the specialist is in a city and has no familiarity with the village or town that that family is actually coming from, right? Are there ways in which we might be able to think about high quality being more flexible across systems of care, right? Can we match the complexity of an evaluation to that of clinical presentations that we're seeing in a way that allows us to move services forward in community settings? And so we've been trying to think about, the idea that we might be able to shift where expertise lives. We might be able to embed services in local communities or clinics. We may be able to use telemedicine. We may be able to change how that care is delivered or what our processes look like in terms of who we're training to be able to be our partners in identifying autism. And can we already kind of leverage the resources we do have rather than being concerned about what we don't have to shift what we're doing? So probably about 15 years ago, our first approaches at changing sort of screening and diagnostic practices were really in teaching folks how to use a tool that was developed at Vanderbilt called the Screening Tool for Autism in Toddlers and Young Children, or the STAT. This is a tool that we would train pediatricians or other providers to be able to do simple 15 to 20 minutes of interaction and come up with risk-based sort of evaluation scores. What we found is that if you did this well and you trained the right type of providers, you could get folks like pediatricians or behavioral specialists who worked in health centers to accurately identify many cases of autism. But one of the problems is that providers in those locations will already complain about the time that they have to be able to see the patients that they need to care for. That asking folks in these locations to do more for populations that are oftentimes very under-resourced is a very big ask, right? So we started to think about, are there ways that we could push our expertise into local communities? Might we not ask someone of a pediatrician who lived in several hours away from our center to do more, but could we use Zoom or other telehealth technologies to be able to bring our expertise to those locations? So a decade ago, before anyone had had a medical visit via Zoom before, right? Before the pandemic, right? Which changed everything about everything for so many aspects of care and life. We started doing just that. We would teach folks in a rural location to administer the stat. We would Zoom in and watch it. We would have the scores. We could interview. And what we were able to demonstrate is that we could identify many, many children very accurately at young ages. And in so doing, decrease waits for services while actually seeing more children. When you're able to do something after a screen rather than tell someone to wait, you're more likely to see practice change over time. So this was wonderful early successes, but one of the problems was that this telemedicine solution required 2 people to deliver it. We had trained somebody at the distal location and the expert, right? So rather than being less resources, we're actually asking for a little bit more, just in a different variation. So we thought that maybe we should develop a tool explicitly for that setting. Maybe we could develop something where we could talk an untrained provider or parent through play-based exercises and come up with a way of using the toys, the tools, the things that were embedded within that home or that practice location to identify autism. And that's what we ended up with, was the TAP, or the tele-ASD-PEDS, where it was a 12-item play-based task. We're asked to observe children. We could walk in real time families through tasks. And then we were in the midst of testing this tool in 2020. In March of 2020, we were halfway through our clinical trial, and the clinical trial was, not without irony, shut down because we couldn't do the in-person validation of the telemedicine. But what we ended up with was this capacity to do an accelerated field trial of this tool, quite literally globally at the time, because there were folks around the world who were saying, we can't go into the SOTIS preschool anymore, right? We're at home and we need to provide care. And what we're able to do is get a great volume of data very quickly, that paradigms like this may actually be able to transform ways in which we identify, that we may be able to offer rapid and time-efficient screening or triage processes in local communities that could help us solve, on a population level, access issues. We never designed our tool or our telemedicine processes to be for everyone. We were designing it for rural locations. And one of the things that's highlighted to us is that not only the tool that I'm presenting today can be used in a telemedicine format, but we can also do something very similar in in-person formats as well, that we can teach a simple interactive screening procedures and scoring procedures to a great variety of professionals in order to help us solve the problem of early action. And so, that's what we are trying to do. I think there's some, in our state, we're studying how we can look at telemedicine to do this, but we have other providers who are looking at how we might be able to do this in person. I'm going to talk to you a lot more in detail about the tool, and hopefully slow down and talk about it at later presentations. But just wanted to give a brief introduction that I think, similar to all the discussions that I've had with such tremendously caring and compassionate professionals here, we're globally struggling with this idea of how do we actually screen, identify, and serve families well and quickly. And that to do that, we will likely need to think about new tools, new processes, and new professionals. So I'm thrilled to be here to learn about how you guys are thinking about those solutions. And it's very flattering to think that providing some training or resources from our end might be a part of the solutions you come up with too. So thank you. I know I'm probably past time already for the first bit of the talk. Thank you.